Hi, my name's Robert Lawson. I'm the Business Development Manager with Power Health. I'm here to introduce my colleague Garth Barnett as a speaker for IHACPA Activity-Based Funding Conference this year. Just a little bit about Garth. Garth is a CPA with over 3 decades experience in accounting systems, financial management and reporting, including importantly 27 of those years in the health industry. Garth is a strong advocate for the use of patient costing and benchmarking as a key tool to drive hospital efficiencies. He draws on his past experience in senior public healthcare management roles to engage and educate hospital management, clinicians and finance managers in this process. Garth is highly sought after for his education workshops and benchmarking studies in activity-based funding and costing. His experience includes statewide PPM costing implementations in South Australia, Northern Territory and New South Wales. It's my pleasure to introduce you to Garth, and I hope you enjoy his session. Over to you, Garth.
Thank you, Robert, and welcome to all the ABF delegates. So my main aim today is really to get you all excited about utilising patient costing, because patient costing contains a huge wealth of information which LHNs can use to basically monitor their performance and, most importantly, target areas for improvement. Unfortunately, at the moment, the majority aren't utilising patient costing information to their full capacity. So if you look at IHACPA's 2021 report into patient costing uses, only 1 in 6 LHNs actually use costing data for management reporting. Less than 1 in 3 were using it to support clinical models of care. Only just over half use it to justify business cases. So I don't know how the other half are justifying their business cases. 72% were using it for benchmarking. So there's probably around about 28% of health units which aren't actually using their costing information at all for internal purposes, just using it for the NHCDC soon, which is a little bit sad. So in this presentation, I want to share my experiences over the last couple of years where we basically used the costing information to improve the performance of an LHN by 8% over 2 years. So I want to talk to you about how I've come up with a bit of an ABF framework. So the most important thing is to actually develop a suite of reports that you regularly get out to users. Ideally, this will be quarterly based on a regular costing. And most also importantly, that you do it on a reasonably timely basis, preferably within about a couple of months of when you actually close off the general ledger. The other important thing is to actually embed the actual responsibility structure of your health unit within the costing system, because this allows you to actually disseminate the information easily to your users. So costing information is at encounter level, but you'll want to actually present that at summarised level, both at clinic specialty level and then further up at a division or a directorate level, depending on your structure. So that's very important. The other thing which can improve your reporting is to actually embed some useful reference tables into your costing system. So things we look at are things like IHACPA length of stay to benchmark against actuals, and also things like cost buckets or, say, jurisdiction averages, which will enable you to actually drill down and look at individual cost components. So that's very important. The other thing I just want to briefly touch on is make sure you leverage your costing system to get as much value as you can out of it. So things which are really easy to do are, for instance, running the HACC module, which you can run easily on the diagnosis and the condition onset. Other things like you can actually bring in your billing information to actually identify misbilling with things like prosthetic revenue. And another thing which is certainly worth considering is actually using it to develop ABF budgets by developing ABF RVUs, because it's a lot more meaningful to actually set your budgets using ABF rather than some sort of historical basis, because you'll get more accountability that way. So now touching on ABS performance reporting. So in terms of what, I suppose, tool set I tend to use. So the most important reports are for each of the different encounter types. Develop one which is basically at a clinic or a specialty level and a classification. And from that, you can basically develop subset reports which will identify your material increases in length of stay and also costs compared to funding So because these are basically the extreme areas basically you want to identify to actually drill down further. The second stage is actually develop some supplementary reports to actually get down into understanding the fundamental reasons as to why you've got those variation. So the first one I tend to actually look at is actually linking HAC or incident data to understand where that's actually a driver between the higher length of stay and also the higher cost. Second thing I then look at is basically reviewing the high cost length of stay activities, and particularly those which have low complex DRGs, because often they are often due to poor coding or clinical documentation. So just for an example, last year we pulled out about 100 medical type patients, and of those 40% actually changed DRG, which brought in significant extra funding. More importantly, we actually documented the reasons behind that and actually took that back to educate the clinical teams because we want to fix these issues on an ongoing basis. Another example is to benchmark same-day rates for elective surgery and ensuring that, that we actually got bringing the right proportion of same-day versus overnight compared to other benchmarked hospitals across the state. The next thing is to actually go and look at where the length of stay isn't the biggest driver of the actual increased cost compared to funding, and then actually drill down further to actually understand the reasons why. And that's where you want to go and have a look at your cost buckets. So was this increased because of higher use of prosthetics, pathology, or say increased nursing ratios compared to what the average funding is for these? So you actually want to drill into the details, and so you can actually have those discussions with the clinical teams as to where you've got some sort of clinical variation. A bit of an example of one of the reports we do. So what this is doing is it's basically overlaying the incident data in terms of the OBD variation and the cost variation with the actual length of stay and cost variation versus funding. So what you can see here is, for instance, in the mental health DRGs, they are very much driven by the incidents which are occurring within those specific areas. And we actually have the details behind what those particular incidents are. So we can actually start having that discussion with the clinical teams as to how we can reduce those to hopefully improve the patient outcomes for the patient, as well as reducing the costs. So that's something which is really easy to do. In terms around the incidents, we had an example of, for instance, in terms of 3 rehab wards, where we had 1 rehab ward which had 2.5 times the incidents compared to the other 2, particularly with a big increase in the number of falls. So again, this allows us to have that discussion with that particular ward and try and understand why that's occurring and minimise that, because that will have a huge reduction in length of stay and cost, and most importantly, better patient outcomes. So in conclusion, costing information really is a key tool to value add and assist in improving the performance and decision making of an LHN. I found to successfully embed ABF reporting framework, it's important to actually formally document what you actually find each time you run the costing data, and actually have some clear actions for the clinical teams to actually improve upon, because you actually want to follow that up the next time you actually do the costing run and analyse the information to ensure that you are getting that improvement as you expect. And that's the way you keep driving improvement against the NEP. It's not a coincidence that as I've travelled around Australia, you find that the LHNs which are really switched on and using ABF reporting within their environment are the ones which tend to be performing better. So please, I'd like to encourage that all the costing users out there get out there and actually spread the love and get their information out there to help the performance of their organisation. Thank you.
And thank you very much, Garth. If people are looking for a bit more information or to ask any questions, you can see Garth's contact details down there. And on behalf of Power Health, we just wanted to thank you for listening in on Garth's session. And that's it. Thank you very much. Bye.
Cheers.